CME credits, and this is doable through an all-access pass. This all-access pass will be differentiated for residents and fellows and for attending level or faculty surgeons. So please join us in the future. If you want to have CME credits, please do it through the all-access pass. So coming 2025, please keep tuning in. Free content, high quality, always available. But please use the all-access pass if you need to claim CME credits. Thank you so much.
And we're live in 5,
4, 3,
2,
1.
Hi, good morning. It's my pleasure today to introduce Bob Fisher for our Epilepsy Grand Rounds. Bob is a juggernaut in the epilepsy community. He served as editor-in-chief for Epilepsia. He's led the American Epilepsy Society. He's the Masla Saul Professor of Epilepsy and Neurology at Stanford. And he's been a lifelong leader in epilepsy research, advocacy, and study, particularly of stimulator-based treatments of epilepsy. Bob, take it away. Thank you.
Thank you very much. Let me share my slides. Can anybody see them?
Yes.
Good. Okay. Thank you for inviting me and letting me talk remotely, although I love visiting Seattle. We're going to talk about deep brain stimulation for epilepsy and a few related topics as well. There are a few pioneers in this area. I don't count myself as one of those because DBS has been going on since the 1950s. A Yale neurosurgeon named Jose Delgado was in the New York Times for being able to stop a charging bull with an implant in his brain. As best I can tell, he put it in the internal capsule, and when stimulated, the bull would just go in small circles. But the piece reads, "The brave bull bore down on the unarmed matador, a scientist who had never before faced a fighting bull," which, by the way, becomes evident in the video, which I have, showing him running behind that little wooden barrier. Dr. Delgado, the scientist, pressed a button on a small radio transmitter in his hand, and the bull braked to a halt. So it does occur to me that this is not the only time that DBS has been associated with a lot of bull, but I'll try to stick mostly to the evidence. And I should say at some point, like now, that I don't have any financial connections with any neurostimulation or neuromodulation company. Years ago, I did some talks for Medtronic, but not for years. So this. Okay, these are the people that I consider the real pioneers. Irving Cooper, shown next to an unidentified look-alike, and really a family business. Marcos, Francisco, and Ana Luisa Velasco in Mexico City. Marcos has passed away, but he was the neurologist. Francisco, neurosurgeon. Marcos's brother, and Ana Luisa, Francisco's daughter. Maybe Marcos's daughter, I forget. Irving Cooper was the first to explore DBS for epilepsy, except for someone named Robert Heath, who was a psychiatrist who was stimulating septal nuclei in other regions in patients with epilepsy, but mostly for study and alteration of mood. And then Marcos and Francisco were pioneers in specifically looking at epilepsy. Irving Cooper was studying epilepsy mixed with cerebral palsy, movement disorders, and it was, frankly, although he was a brilliant pioneer, was often hard, at least for me, to interpret his work. These are the sites in the United States where DBS has been tried in people. Many more have been tried in animals. The three in red have had large randomized control trials leading to FDA approval. Years ago, vagus nerve stimulation. Well, heck, they're all years ago by now. But vagus nerve stimulation has been around for 25 years. The only approved FDA site for neurostimulation is the anterior nuclear group of Thalamus. And this was an original target of Irving Cooper, the neurosurgeon from Valhalla, New York, that I showed before. He, I think, was doing it on the basis of a fortuitous outcome in a patient who had an anterior cerebral artery stroke and had improvement in Parkinson's disease, and then he decided to try it for epilepsy. The Velascos considered it a good target because it was on the circuit of PAPES, originally pronounced Papish, I get asked, but most people call it PAPES. And that is a circuit related to memory and emotion, which links the outflow tract of hippocampus through the fimbria and the fornix, curving around to the mammillothalamic tract, and then, I'm sorry, to the mammillary bodies in the hypothalamus. And then from there, the mammillothalamic tract goes to the anterior nucleus. The anterior nucleus goes to the cingulum bundle, which tracks along the cingulum and callosum back to entorhinal cortex and hippocampus. So that is a fortuitous loop that involves both mesial temporal lobe and mesial anterior frontal lobe, which is where the majority of seizures occur in humans. So I was involved in a number of pilot trials, or there were a number of pilot trials. I was involved in some of them. And this led to a pivotal trial, which showed efficacy in a blinded study. This was published in 2010, so it's been around for a while already. What this is showing is implantation and then stimulation on after a month. By that time, there's already been improvement of about 20% in seizure frequency, which various groups have called a microlesion effect. And it might be a microlesion effect, but it could also be a placebo effect. And it could also be something much less interesting, which is regression to the mean. What that means is that patients don't go into invasive surgical trials unless they're doing badly. And I've had, some over the years who called me up and said, "Hey, doc, I haven't actually had a seizure for a few months. Why don't we postpone this and just see how it goes?" So if somebody's always going into a trial when they're doing badly, chances are your next measurement is going to be better. But having said that, that's the point of placebos. So you can see the divergence of the curve. In orange at the top is the seizure reduction in the sham stimulation group, and in the gray at the bottom in the active stimulation, which happened to be 5 volts in this particular 14.5 versus 40.4% reduction, which was statistically significant. And patients could not feel the stimulation. At least most of them couldn't, unless there was some leakage into the chest causing paresthesias. So it probably was a true placebo trial did not have to do what the vagus nerve trials did, which is do high versus low stimulation, because the stimulation in the throat was perceptible. So this is what convinced me that it really was working. When we turned on the patients who had been at sham stimulation, they came down to the same improvement level as those who had had active stimulation without themselves knowing whether they'd been on sham in the blinded phase or not. One of the peculiarities about neuromodulation for epilepsy seems to be that it comes on slowly. And that's another subject I could give a whole 1 hour talk about, going through the various theories about why there is gradual improvement, but there is for VNS, DBS, and RNS. So 3 months is not generally long enough to see the most significant part of the improvement in treatment. This, by the way, is very different from, say, treating tremor, as your neurosurgeons or your neurologists would know, with globus pallidus intermediate stimulation or subthalamic stimulation, where you can see the improvement right in the operating room. So that's physiological. This improvement more relates to, chronic pain, remodeling of connections, changing networks, changing receptors, all that sort of slow stuff. So over time, you get to about a 70% median reduction in seizures. So that's with the anterior nucleus of thalamus, and I didn't want to dwell on the old trial results because I think most of you who care would know them already. The concerns of implants are the usual ones. Infection, hemorrhage. It's not particularly a large problem in most series of most patients. But there were more subjective reports of depression and of memory problems in the stimulated group versus placebo. Didn't really show up in the formal testing, and it didn't seem to persist in follow-up study done a few years down the road. But there is enough transient increased depression that I'm not recommending anterior nucleus stimulation for patients who are, say, potentially suicidal. We have implanted some with mild depression and watched them. So the next nucleus that we've been interested in stimulating, and all these others besides ANT are off-label stimulation done for the benefit of individual patients, is the Centromedian nucleus, which was actually the first nucleus in which I was involved. You can see the CM localization here. It's considered part of the, quote, non-specific thalamic nuclei that isn't just a throughput straight to cortex. The main connections of CM are to the basal ganglia, particularly the caudate, the putamen, subthalamic nucleus, substantia nigra. But it has widespread connections: ventral thalamus, the other intralaminar nuclei, the nucleus reticularis, sensory motor cortex, and premotor cortex. The initial study was the pioneering study of the Velascos in 1987 with 5 patients who had generalized or multifocal seizures, mostly Lennox-Gastaut patients. I followed that up a few years later with my first clinical trial on 7 patients, and had about a median 30% improvement in seizures over placebo stimulation. It wasn't a very good clinical trial, I must say. I was on the start of my learning curve. The numbers were small. We tried for 8 patients, but one got a subdural and dropped out. And then we just were unsure at that point of how much of a carryover effect there was from stimulation, but it turned out to be more than we thought. So, I'm not too confident of the results, but we only saw trending in improvement with that. There has since been a recent controlled study by John Archer's group in Australia, Dalek, the first author. And here's what it showed. There were 19 young adults with Lennox-Gastaut syndrome. They had the usual mix of seizures that you have in LGS, did Centromedian, DBS, or sham for 9 months. 3 of them were blinded. They randomized 3 months after surgery to let the micro lesion effect dissipate. They kept the seizure diary, which is notoriously awful in accurately tracking seizures like multiple atonic, atypical absence, tonic seizures per day. But they also counted electrographic seizures in a 24-hour EEG. There were 50% responders. Median seizure reduction was 47%. They did not quite achieve significance, close, but not quite at the 0.05 level between CM stimulation and sham stimulation for seizure reduction. The EEG improvement of seizure counts was, however, significant. So we can consider it at least, I don't know, use the royal we. I consider it a moderately positive study, but not definitive, because they didn't have statistical significance on the seizure reductions. So the next nucleus that we have looked at is Dorsalis medialis, which is also called medialis dorsalis or Dorsamedian nuclei. This has 3 subnuclei, as is shown in the slide, but by and large, the strongest connections are with prefrontal cortex. It also reaches out to some other areas. It's interesting, too, that it's on the same network as the Centromedian nucleus, in that CM stimulation will activate about half of the neurons in Dorsalis medialis. Let me get rid of that. So I will say that we did do stimulation in one patient acutely who developed some mood discomfort as we did the stimulation, and it's not been someone at our center that we've been chronically implanting, but we would if we had specific evidence that it was involved in the network. Ed Bertram published a paper in which he said neuronal loss in the medial dorsal thalamus may be the consistent pathology in limbic epilepsy. This was in rats with the hippocampal stimulation model to create status epilepticus. DM is close to ANT, and in fact, if the surgeon uses a superior transventricular approach, which is what we used in the Sante trial, it's quite likely that the most distal contact is, in fact, in Dorsalis medialis. So you can get a little bit of a two-for sale there to stimulate DM as well as ANT with the same electrode. That's shown in the picture here. And also in the right side of the picture, you can see that discharges in the anterior nucleus are highly reflected in the ipsilateral dorsalis medialis in a couple of different places. Okay, the star of the show, so far as I'm concerned, is the Pulvinar nucleus, the most posterior and the largest nucleus in thalamus. Those of you who are close to my age may remember the comedian Rodney Dangerfield, who was always complaining that he don't get no respect. Well, the pulvinar hasn't gotten much respect either. We thought it's just really involved with parietal and occipital lobe, and maybe makes the alpha rhythm in coordination with visual cortex and so on. But although that's true for the lateral pulvinar, the dorsomedial pulvinar, and the inferior pulvinar being involved with parietal, occipital visual areas, the medial pulvinar has an amazing widespread group of connections. You can see it to the amygdala, superior temporal, orbitofrontal, dorsolateral prefrontal, cingulate, insula, superior and inferior temporal. So it's a well-connected nucleus on the medial side. Here we have an example in one of our patients where stimulation of the pulvinar appears to interrupt hippocampal spiking. An article by Rosenberg looking at chronic stimulation of the pulvinar. This is way back, 2009. I think it's the first that looked at this, showing that it could help seizures, and also you can record in the pulvinar different patterns of discharges: low voltage fast, spikes and slow waves, and rhythmic spike waves. And these patterns may differ a little bit from neocortical seizures and from mesial temporal seizures. Here's a paper by Filipescu indicating that DBS in the medial pulvinar shows that seizures were triggered by hippocampal electrical stimulation, and pulvinar stimulation shortened the tonic phase of the seizure and kept the patients conscious for longer, showing some of the discharges in the figure. So there's been building evidence for pulvinar stimulation. Here is a paper that's not out in print yet, but online. 5 patients with TLE did sensing of the local field potential in the pulvinar, which you can do with the Medtronic electrodes, not with the Boston Scientific electrodes. The median seizure frequency reduction is 79% at 13 months, and medial pulvinar stimulation produced a better outcome than lateral. You see spikes in the left anterior hippocampus and the left posterior hippocampus reflected in the left pulvinar, but not, for example, in the left centromedian nucleus. And these spikes are delayed by a bit from the hippocampal onset of the spikes. You know, it's not like seizures start in the thalamus. There's a delay from your seizure focus to the thalamus. But thalamus is on the propagation pathway, almost always. It's on the network, and it is involved in the evolution and the development, as well as the propagation of seizures. You know, we talk often about where seizures start, but that is clearly becoming too simple a concept. It's useful if by that we really mean what can we lesion to reduce or stop the seizures, but it doesn't really mean that's necessarily where the seizure starts. You can lesion a phone call by cutting the line on the power pole outside. It doesn't mean that's where the conversation originates. Seems increasingly, instead of putting in clock cycle-based stimulators, people are putting in responsive neurostimulators to do deep brain stimulation in thalamus. Here's a study with 27 patients, had RNS electrodes put in CM and 9 in ANT, anterior nucleus of thalamus. mean follow-up 22 months, there was a 25 to 49% improvement. In 6, 14 had a 50 to 99% improvement, and 1 had a seizure-free response, which is actually pretty similar to what you see with standard DBS implants. So I know this can be done, but I haven't seen clear evidence yet that it's better to be done. And perhaps that's because in addition to the response to the seizures, which may be occurring 2 per week, the RNS is typically going off 1,000 to 3,000 times per day, depending upon what we set the upper limit for stimulation to be. So I think it's doing a lot of chronic neuromodulatory stimulation as well. So on the basis of what I've shown you so far, these are what I consider so far to be the promising thalamic nuclei for DBS stimulation. Dorsalis medialis, Pulvinar, CM, and the one that's has the most experience and is approved, anterior nucleus of Thalamus. And there may well be others. The Thalamus has a lot of nuclei. So how do we decide which one to choose? And here I'm talking about choosing not on the basis of what is approved, but what is most likely to help individual patients. So, our thinking at Stanford has been that it seems that it should depend upon the seizure network. Here you see a case where seizures start in the inferolateral temporal cortex. You see the low voltage fast activity that I've circled here, and it spreads to anterior nucleus first, in this case, with low voltage fast here, and then later to the pulvinar. But that's not always the case. There are patients in whom the anterior nucleus doesn't seem to be involved at all in the propagation of the seizures. And for those patients, although I can't prove it to you at this point, it seems kind of logical that that would not be the best place to put a neuromodulator if it's not even involved in the network and the propagation pattern of the seizure. So, this is the decade of personalized medicine. Maybe this is something that we can personalize. One of the first things that our group did was use corticothalamic evoked potentials in order to try to map the connectivity with the different thalamic nuclei. And you can see there are 2 ways of doing corticothalamic mapping, but turn out to be mostly the same. And yet you can see that the connections that were maximally involved and the evoked potentials, with one exception, turn out to be the same nuclei. So these corticothalamic evoked potentials would, probably be a useful way to map the network, although they are, invasive. You've got to have electrodes in the head to do that. You could also look at coherence among different channels in your depth electrodes and your surface electrodes. And this can be informative, but depending upon which method you use, you can get rather different results. Each of these colored boxes is showing just a color code of how the unreadably small labels here about which contacts and which electrodes you're using are correlated with the different electrodes. And of course, every electrode is correlated with itself, so you get a unity diagonal along the grid. And where the colors are brightest, like most yellow, that's where there's a stronger connection. And most specific here is Granger causality, which has a directional component to the coherence among the electrodes. But that too requires invasive study. Now, let me shift gears for a moment to a laboratory study done by Jin-Hyun Lee at Stanford, I was a participant, that used optogenetic stimulation of the rat hippocampus to provoke seizures. And the advantage there is that you can make acute seizures by stimulating whatever part of hippocampus you want. And you see the light up in 7 Tesla fMRI of the rats. Turn out to be 2 distinct patterns. If you stimulate the dorsal hippocampus, which corresponds with the posterior hippocampus in humans, you light up the retrosplenial cortex and the thalamus, namely the circuit of Papes, as we've been talking. But if you stimulate the intermediate hippocampus, then activating the septal nuclei and not activating the hippocampus or particularly the thalamus. So, you know, it may make a significant difference, even within one structure like the hippocampus, where your seizures are most active at the beginning of the seizure, in terms of which network it activates. So we started to look at this a little more systemically in people. And what we found is that you can see different focal seizure onset sites here, some of which, like hippocampus, mostly activates the anterior nucleus of thalamus. But if you're in the posterior insula or the inferior or ventral temporal cortex, or even the amygdala, which you may remember does have connections with the medial pulvinar, then you're activating the pulvinar and not necessarily the anterior nucleus or the medial dorsalis nucleus. And then there are a number of cases where it's like a tie between the anterior nucleus and the pulvinar. So we can diagram this like this. The numbers in gray are the numbers of patients in whom we saw the connections, and I made the thickness of the bars to indicate stronger connections in terms of greater numbers of people involved. And by the way, the collateral sulcus, if you're not sure, I made a picture of it in green, that region. So this was a sequence of thalamic activation. To summarize, it's 17 patients, 24 seizures. Most of these had mesial temporal seizures. The thalamus was always involved, but was never first. Anterior and pulvinar were both involved in 88%, and pulvinar was more often first with those. There was unfortunately variation, seizure to seizure, in a given patient and within patients. There was also rapid neocortical spread and sometimes late thalamic spread. Our surgeon, Dr. Vivek Bush, has taken to coining it multinodal stimulation. At least I think he coined it, although it's a little bit too grandiose for us at the moment because we've only done binodal, 2-node stimulation. But when we're not quite certain which nucleus is best on the network, we have taken to implanting not 2, but 4 thalamic electrodes for stimulation. You can either do that with 2 Medtronic equipment, or you can do it with Boston Scientific equipment, which is off-label right now for epilepsy, but I think soon will be on-label. So we did that in 11 patients who had mesial temporal, orbitofrontal, periventricular, or insular seizures. It looks like this. And this is not a slide for reading through, but at an American Epilepsy Society meeting, we published how it changed our management. And you can see that it changed whether we did neuromodulation, where we did modulation. In some cases, it inhibited doing a resection or encouraged a resection. And this was all on the basis of, clinical impression of what the network was involving. What we, and to my knowledge, no one has ever done yet is proven that this approach causes better results than just doing some type of standard stimulation. I think that remains for the future. But we have had good outcomes with our multinodal stimulation patients for the most part. Typically ANT and CM or anterior and pulvinar. And these, in our cases, are with focal seizures. So I will mention that the Mayo Clinic did look at ANT plus CM for multifocal generalized seizures of the type that CM gets implanted for. And they couldn't tell from their series that ANT added much to that group beyond the CM stimulation alone. We've sometimes stimulated sequentially. We sometimes turn them both on together. So it would be awfully nice if we could predict who would be responders without having to do an invasive surgery or stereo EEG recordings to tell. So this is a study that I did with collaborators from Beijing. 18 patients with at least 2 seizure foci implanted with bilateral ANT DBS leads. We hand traced the seizure foci onto a standard Montreal Neurological Institute brain atlas. Got bold signals from fMRI of each patient, calculated volume of tissue activated for each of the contacts of ANT, used human connectome data on 1,000 normals, which is publicly available, to estimate the connectivity between where the seizure focus was located and where the volume of tissue was on the contacts in the implanted leads. And having said all that, and having had a picture that shows highest ANT functional connectivity, pretty well imitating the circuit of Papes structures, the finding was that when the non-invasive human connectome showed good connectivity with the seizure focus and with ANT, the outcome was better, which is what you see in this chart. So maybe there will be some non-invasive ways of predicting what the best nuclei are to stimulate. All right, let me start closing down by indicating that neuromodulation is sort of the hot topic now in at least our seizure surgery discussions. I've been going to these weekly conferences for over 30 years now, and in the past, an awful lot of the time, we would say, yeah, we can't help you. The drugs didn't work, which they don't in about a third. And we either can't really find where the focus is, or it's in a place where we can't take it out. It is very rare in our conference now to say we can't help. There's nothing we can do. There's usually some type of neurostimulation that we can at least try. And I tallied up from the 2022 National Association of Epilepsy Center reports the number of resections, counting laser ablations, that were done, and the number of neuromodulation implants. DBS would be quite a bit higher because it had just been approved recently prior to this survey, and this does not count battery replacements. So it is a happening thing. Well, then what's the conclusion? So DBS of ANT seizures are reduced to about 1/3 by 5 years. We need to do better. About 15% become seizure-free for 6 months or more, but it's not a cure. And although sometimes we reduce medicines, I think we may have only one patient who's gotten off medicine. Seizures almost always involve thalamus at multiple varied nuclei. Personalizing the network and stimulating multiple nodes might help. I didn't talk about it in this talk, but changing the character of stimulations to also be more personalized would be another avenue of trying to help. With neurostimulation, we can help many more and rarely have to say we can't help. And to improve the results, I think they could be improved by better patient selection, targeting training for more neurosurgeons. Sorry, not just the ones at the specialty epilepsy centers. Stimulating to the individual seizure network, new customized stimulation parameters, perhaps responsive DBS, and making brain stimulation non-invasive would be a very worthwhile thing to try. Or as Yoda says, there is no try, only do. That's all I have. Stop sharing.
Thanks, Bob. That was a great talk. One question that comes to mind from my point of view is, are you targeting unilateral or bilateral for most of the stimulator patients you're talking about? Or alternatively, let's say you have a really scarred up, tricky placement unilaterally, and there's only, in effect, one side that's easy, viable targeting for the surgeon. What are the outcomes like unilateral versus bilateral?
Sure, you cued me that that question might come up. So I did make two slides on it. This is a rat study from the group in Ghent, Belgium, and it's with rats who had status from intraperitoneal canic acid. And the bottom line for this lower spots on these graphs are fewer seizures. That unilateral helped, but bilateral helped more. Don't know quite how much that applies to the question you asked, but that's the only animal study I could find on unilateral versus bilateral. And then there were 7 patients with unilateral anterior nucleus implants, and CM as well as ANT. And it looks like the degree of improvement, the orange bars are higher in bilateral than unilateral. So I think there's very little evidence to answer your question. I think it may be the case that unilateral helps, but bilateral may help even more, even when there's a unilateral seizure focus.
I guess as a follow-up question, in your stereo EEG surveys for your surgical candidates, are they having thalamic locations targeted bilaterally in stereo EEG assessments?
Most of the time, if everything has been clearly unilateral in the workup, not even interictal spiking on the other side or a neuropsychology finding to suggest bilateral trouble. We haven't felt that it was right to implant both sides. So we do some unilateral implantations. For most of them, at least having a survey electrode in the contralateral hippocampus would be the most common.
I guess another follow-up to that would be, what sort of surgical risk is there is your team seeing in terms of more aggressive thalamic surveys for stereo EEG?
We haven't, well, we never add extra electrodes. That's point one. We just extend the trajectory of electrodes that we're going to do anyway into thalamus. And sometimes that might involve an alteration of the trajectory, but no extra electrodes. We've never had a thalamic bleed. We've never had a thalamic infection, knock wood. We do seem to get the usual kind of 1% mostly superficial brain bleeds from electrodes. But we haven't had a complication yet in thalamus. And there's published literature on this that antedates us doing that, that suggests that it's also pretty safe. Although if a lot of people do it a lot of time, there will someday be a hemorrhage in thalamus.
A question from one of our epilepsy physicians, Dr. Kai Borboon. I'll read it out for you. Since Pulvinar connects to multiple regions, is it a good target for stimulation in generalized epilepsy? And I guess his follow-up question is a little bit similar. In your opinion, what is the good target for generalized epilepsy?
It's a great question. We have done a few CM plus Pulvinars, mostly motivated by seeing what looks like significant posterior seizures in addition to others. But I don't know. Our seizure conferences these days are exciting and interesting, but they're so much driven by speculation. And, I would be speculating on what the other best nuclei would be. Honestly, the reason we're doing, maybe I shouldn't say this if the recording is still going on, but a large part of the reason we're now going with 4 lead electrodes is our indecisiveness about which the best electrodes will be for a particular patient. So we may put 4 leads in, and we may try ANT. If that's not working, then we may go to Pulvinar or to CM, or sometimes, not sure for reasons that I can entirely explain, we may turn all 4 electrodes on at the same time. But it's because we can't decide which is the single best place to stimulate.
Well, I don't see any other questions there, Bob, and thank you so much for talking with us today. I appreciate it, and hope to see you soon.
Yes, thank you for inviting me.